This was a 1-day-old infant who presented with abdominal distension, and we have this abdomen radiograph, and you can tell there is this repogal type enteric tube with the tips projecting over the gastric body, but we have diffuse abnormal dilation of all bowel loops throughout the abdomen. We have a lack of bowel gas in our rectum, but if we draw our equator along where we think the umbilicus will be, we can see that there are as many dilated bowel loops above the equator, so in the northern hemisphere, as we have in the southern hemisphere. So this is concerning for a distal bowel gas obstruction. And that's the appearance that we're going to have when we have such diffuse dilation, gaseous dilation of bowel throughout the abdomen. This is a distal bowel gas obstruction pattern. So the next step in the workup of this patient will be contrast enema. So this patient came to our fluoroscopy suite for contrast enema later that same day, or maybe it was the next day. We always start with a scout radiograph just to get a lay of the land, make sure the enteric tube is in the appropriate position, and we have a similar abnormal. So after our scout radiograph, a tube is placed in the rectum of the infant and water-soluble contrast is slowly administered. This is the left lateral decubitus lateral view of the rectum. And in the setting of suspected distal bowel gas obstruction pattern, this is one of the more important images to get. So we inject contrast and we slowly watch the contrast column as it moves in a retrograde manner. And this area right here in the rectum is something that we're going to pay close attention to as we continue to fill this colon in a retrograde fashion to see if this goes away or not. One of the differential diagnoses of a distal bowel gas obstructive pattern is Hirschsprung disease, and that is where you have an aganglionic section of rectum. So it is unable to relax, and so you'll have focal narrowing of bowel at that level. And so as we continue to inject or instill contrast in a retrograde fashion, we are sort of at an oblique angle here. We have this clear transition point. So we have a narrowing, focal narrowing of the rectum at this level with upstream dilation of colon. So this is that sort of funneled appearance of colon at contrast enema in a case of Hirschsprung disease. And so we'll just make sure that this never does open up very well. It's continuing to be narrowed focally right here with upstream dilation. A lateral rectum filling shot. So this is where you look at your rectosigmoid ratio. So normally the rectum is the stool repository prior to defecation, and so the rectum will be larger than the sigmoid colon. In this case, the rectosigmoid ratio is reversed, and so the rectum is smaller than the sigmoid colon. So this is the classic appearance with Hirschsprung disease. Of course, we continue filling to see if there are any additional areas of narrowing. There's a positive arrow sign showing you that focal narrowing of the rectum at that transition of aganglionic to ganglionic rectum and sigmoid colon. We'll continue to fill with water-soluble contrast as much as we can proximally. Again, we are making sure that this never opens up and it's continuing to be abnormally narrowed here. Patients with Hirschsprung disease can be challenging to get that contrast to reflux all the way to the proximal ileum. But as this case is, so this is a case of Hirschsprung disease with abnormal rectosigmoid ratio and dilation of sigmoid colon upstream because of that aganglionic section of colon.